Alrighty. Good afternoon, everyone, and welcome to today's webinar. I'm Donna Rice, the Chief Operations Officer for Diabetes Sisters, and I'm thrilled to have you all here with us today. I'm also joined by Karen Graffio, Diabetes Sisters Program Manager. We really appreciate you taking the time to be part of this important conversation. Each year, the American Diabetes Association updates its standards of care. Think of it as an official guide to the best practices for preventing, diagnosing, and managing diabetes. These guidelines are based on the latest scientific research, ensuring that people with diabetes receive the highest quality care. Today, we'll walk you through the key updates for 2025 and how they impact your daily life. So whether you're living with diabetes, you're at risk, or supporting a loved one, these updates will help ensure that you have access to the best care possible. Our speaker will break things down in a clear, easy to understanding way, highlighting what's new and what it means for you. So now it's my pleasure to introduce our esteemed speaker, Kathy Warwick. Kathy is a registered dietitian and certified diabetes care and education specialist. She's the owner of Professional Nutrition Consultants, LLC, based in Madison, Mississippi, where she provides diabetes education and support, long-term care consultation, hospital and hospice consultation, wellness program services, media communications, and medical legal consultation. Kathy's passion lies in empowering both people with diabetes and the healthcare professionals who support them. She has been a dedicated advocate for policies that improve access to diabetes education, medical supplies, and comprehensive care. She's a frequent speaker at both community and professional events, and she's led numerous national webinars on diabetes-related topics. She's also a published author, having contributed articles and a book chapter for the American Diabetes Association's Guide to Nutrition Therapy. Currently, Kathy serves as the Professional Development Chair for the Diabetes Dietetic Practice Group of the Academy of Nutrition and Dietetics. She's also a past president of the Mississippi Academy of Nutrition and Dietetics. So we're so grateful today to have such an experienced and passionate expert with us. So during or after the presentation, please, if you have any questions, put them into the Q&A, and for sure we'll answer them after the presentation. So please join me in giving a warm welcome to Kathy Warwick.
Hi, everyone. Thank you for joining today, and I'm hoping that this will be a really good experience for you, and you'll have something to take back to your care team and to good things to discuss with them. What I hope you'll learn today is just exactly what are the standards of care, and Donna did a good job of laying that out, and then what use will that be for you living with diabetes, and how can that help you get the best care? I want you to be able to, I hope at the end, name 3 important things that you take away that you can go back and discuss with your healthcare team. So as Donna said, it's published annually. It's over 300 pages and 17 different topic sections. And I guess their mission statement here is that diabetes is difficult, and it requires us as medical care professionals to really know what the best practices are and to support you living with diabetes so that you have a better opportunity to stay well and to live a full life and have fewer complications. And we hope that you know, we want to practice at the top of the level of evidence that's out there. So the experts who put this together look at all the recently published articles and research out there, and then they critically decide, you know, what is the best practice or what's a good guide for best practice. There's also so much new information all the time that the American Diabetes Association on the website, if you go in and look at these different topics, you'll see this little red ribbon, and it means that there's been an update since the publication of these standards in January, because there's new stuff all the time that comes out. And so the new things will be posted throughout the year on the on the Academy of, I'm saying my organization, on the ADA website. So check that out also. Section 1 is all about how we can improve our care and promote health and well-being. One of the things that I am so glad to see being emphasized to healthcare providers is that we have to collaborate and make decisions with you about what you want and what you feel is important and what you need help with and your challenges. We need to make sure that we are asking what the challenges are for you. I learned this early on. I'm going to make a confession, but I sure was grateful that it happened to me when I was a young dietitian. I worked in the hospital and I gave just a fabulous diet instruction to this woman named Josephine, and unfortunately she came in and out of the hospital several times that year. And so, it's concerning when someone comes back and forth to the hospital with the same issue over and over again. And I had, really done the best I could to give her a great diet instruction. Well, I went to work in home health as the next job that I had, and I actually ended up with a referral to go and see Josephine at her home. And she had diabetes, and she'd had a really tough year and in and out of the hospital, as I said. So as I'm driving to her house, and keep in mind I live in a poor underserved state, but as I'm driving through the country and pull up at her house, I see as I'm driving in that she has a garden and she has chickens and she has rabbits and she has, a little small farm that she cares for. When I speak with her, her husband is in the room also, and I notice that he has his foot propped up and it's all bandaged. And we had this great conversation, but essentially, the reason that Josephine kept ending up in the hospital with her blood sugars extremely high was because they couldn't afford insulin for both of them. And she was very concerned that her husband was going to lose his foot. And so she had been giving her insulin to him. So in the hospital, we assumed that Josephine just wasn't, quote, doing what we had told her to do, when in fact, if we had taken the time to talk with her and find out what was going on in her life, we would certainly been better equipped to help her. And we were able to get her some free insulin samples and help her. But that's the point of this entire section, is that we're probably doing a poor job in some cases as caregivers and healthcare providers if we're not really having those conversations with you and finding out what's going on in your life. So we know that although we have all these new medications and all these new technology, continuous glucose monitors and insulin pumps are wonderful and all the things, still, we only have about a quarter of the folks living with diabetes who meet the goals for all three: glucose, blood pressure, and cholesterol. And only 11% meet those goals without smoking. So we're obviously got some ground to make up. We also know that we've got a long way to go in terms of staying on top of and changing treatment when it's not working in a timely fashion. So we need to look at how we can innovate our care delivery. In Mississippi, there are so few certified diabetes care and education specialists and few dietitians that are, available in a lot of the areas in the rural areas. We have embraced our public health community workers and our trained diabetes lay workers out in the community, in a community center in a small small area, there's quite a bit of need and not much access to those big hospitals or the big diabetes programs in the bigger towns. We know that what Diabetes Sisters does, which is positive peer support, can lower your A1C an average of 0.76% or nearly a full percent. So we know that support is very important. It's been shown now that COVID gave us the opportunity to expand telehealth and to expand web-based support, that any interactive telehealth type strategy that gives us the opportunity with two-way conversation, that we can make a difference and we can help even if you're not able to be in our clinic in person. Our care system has basically been based on sick care. In other words, we go to the doctor when we're sick. The hospital seems to pick you up and take care of you when you're sick, but we don't do as much in the way of wellness and prevention. And that's always been something that I've been passionate about. So there are several new models of care delivery that work well. The patient-centered medical home and the chronic care management that's been introduced in the Medicare program all are giving you the opportunity to see the whole healthcare team and get all your needs taken care of. And if you've not seen much about that, it's a real interesting model, but it means that my clients who can't drive or don't have a vehicle or need to come back and forth to the clinic multiple times in order to see the podiatrist or the eye doctor or the dietitian or the nurse practitioner, they're not trying to get a ride or pay someone to bring them to the clinic 4 or 5 times. Those visits are centered around taking care of all your needs while you're there. So it's a great concept. We also need to pay again more attention to those costs. Diabetes is an expensive, stressfully expensive disease to take care of. And a lot of times, again, people making choices between, whether they can buy food or whether they can buy insulin or whether they can buy their testing strips. So as a care team, we need to be very aware that some people skip medications and don't report that to their healthcare provider because of the cost. Now, this is something I'm really glad to see, and it's been included in the standards of care for several years now, but it's really come to the forefront, and that is just what we were talking about with Josephine. How are people managing at home? Do they have a safe place to live? Do they have a safe place to exercise or be active? Do they have access to healthy food? What about insurance coverage and how difficult it is for people to understand perhaps our jargon that we use in the healthcare world? We need to be aware that someone's not unintelligent, but they're not familiar with our vocabulary. So we need to improve our ability to teach and to have those conversations with people when we know that they don't particularly care or know about all the medical terminology that we use. And then we need to know what kind of support you have at home. Section 2 talks all about diagnosing and raising awareness, especially of prediabetes. Almost 80% of those persons with prediabetes have no idea of the diagnosis. And what we know is if nothing changes, most of those folks will progress to type 2 diabetes. So it would be important for us to think of ways to reach people who have prediabetes early in that process. So screening has become important, and the ADA has changed its recommendations that all adults 35 and older should have screening available to them, and we should repeat it every 3 years if it's not showing at that time that they have prediabetes. But many will have no symptoms at all for many years. That does not mean that there's not some sort of damage occurring to blood vessels and some sort of health issues occurring with the prediabetes. And some people don't think of prediabetes as serious. So this is something we need people to understand. This is a great little 60-second test that the American Diabetes Association has. It's online and it literally takes 1 minute. And if you have family members or friends or coworkers that you feel like would benefit from this, they can go online and take this quick test to see at what level they are at risk to develop diabetes. You are probably very familiar with the criteria for diagnosing uh, diabetes and prediabetes, but I wanted to provide those for you. A lot of times, as I was teaching my diabetes classes, I would have many times have people come to class and say, I have pre-diabetes, but then when I saw their lab work that was forwarded from the physician, many times their A1Cs were 6.7 or 6.8, which is clearly above the threshold for diagnosing with type 2 diabetes. So as healthcare providers, we don't want to give you bad news. We don't want to diagnose you with diabetes, but at the same time, we need to be honest and give you that opportunity to really do something. If you have pre-diabetes, that will hopefully prevent or delay moving on to type 2. This is also an important topic for women with diabetes, and I hope that you will share this again with your coworkers, family, and friends. We see I work for an OBGYN clinic as well, and I teach their gestational diabetes classes. But what we find is that um, we don't often realize that someone perhaps had diabetes and became pregnant, not knowing about the diabetes there, and perhaps on an initial visit or an initial lab testing, we find that they already had diabetes and didn't know it. So it's important that we let all those women of childbearing age know that it's important to pay attention to and know what your blood sugar is when you're even planning a pregnancy, so that you can do all you can to have excellent blood sugar control while you are thinking about becoming pregnant. And then once, that first trimester when you're not really maybe even aware you're pregnant, that you're aware of it if you can be. They changed the screening then also for gestational diabetes, which is diabetes specifically occurring in pregnancy, to 15 weeks. I know if you've had a previous pregnancy, you know that by 24 weeks, we would give you that awful glucose drink and test your glucose for at 30 minutes, an hour and a half, 2 hours, to see if you have difficulty handling that load of sugar. Now they're asking us to screen earlier in that process, in the pregnancy, to catch it sooner. And then one thing that's very important, if you had gestational diabetes when you were pregnant, you need to realize that at an increased risk of that becoming type 2 diabetes within the 5 years after that baby is delivered. And this is kind of where we tend to lose ladies in our practice. They don't come back necessarily regularly. You're taking care of new babies and you're busy and it's challenging, but we should be looking at blood glucose and A1C every 3 years for the rest of your life if you were diagnosed with gestational. The third section is on prevention, and thank goodness this is become a new focus for the guidelines as well, because if we can catch it early and we can prevent type 2 diabetes, we'd certainly like that to be able to do that. We encourage, again, activity, being active, healthy eating. And the new thing this year in the guidelines is how important the quality of sleep and the quantity of sleep and the timing of when you sleep should be when we're doing our assessment, this is something we should check, just like we check your blood pressure. It's an important piece of the care that we should be providing. So if you have sleep apnea, or if we know if you report to your care team that you have difficulty sleeping, something we should really pay attention to. We also have new evidence that making sure your level of vitamin D in your blood is adequate is important. It may play a big part in prevention of diabetes. Metformin for some has been a drug we use to prevent diabetes. It can also cause a deficiency of B12. So you want to be aware of that. And if you're having any tingling in your hands and feet, or having any difficulty with a neuropathy type symptoms, you may want to ask your care team to check your B12 levels, because metformin over time can lower your B12. The new weight loss medications, I know you're aware of all of those. They're on TV all the time, but the GLP-1 medications also may, another tip, can interfere with any oral contraception. So if you are taking birth control and you are on any of these GLP-1 medications, realize there's an interaction there, and there are quite a few folks that have become pregnant while on oral contraception when they're also on the GLP-1 new drugs for weight loss. And new this year also is an encouraging, hopeful that we can, at some point, as you know, we want to cure type 1, but there's new testing available for those who may have family members with type 1, and it's available to anybody over the age of 8. There is some new treatment options, and perhaps a way to, again, at least delay the onset of type 1 in someone that does already have the antibodies. Now, this section is overwhelming if you're a healthcare provider, because it's many, many, many pages of what we should be doing every time we see you at your annual care visit, and the assessments we should be doing. You are probably familiar with things like seeing your eye doctor and checking your feet, but we should be checking in also on all these other issues, bone health and memory and depression. This year, new again, is that we should inquire about sexual health. And for women, this is really important to know. This happened to me when I went through menopause, and I was so frustrated. But I had these recurring urinary tract infections. And, I tried all the things that were suggested, of course, and nothing seemed to really make a difference. Turns out that as your levels of estrogen in the body decline, it affects the bladder, and so we should be inquiring about these things. We should be inquiring about it, menopause and the different hormone changes. And I did notice that you have a physician that did a great job of outlining that for the Diabetes Sisters. I saw that this past week. This is where I have spent my life, is helping people understand, where they can improve some of their health behaviors, and how they can really do a great job of taking care of themselves and improve their health. And education, diabetes education and support really should be offered to you when you're diagnosed, every year when you come for an annual checkup, and whenever any kind of complications or transitions in your life occur, because we know that, things happen. People get distracted from their care, because life throws things at you that you've got to pay attention to at times other than your diabetes. And there's no one size fits all approach to eating or activity. So we should really work with you and ask what you want to do. But our goals for healthy eating in general are that we should try to pick as much as we can kind of whole foods and as close to the condition they came out of the ground, such as fruits and vegetables, or those healthier options that we can think about, and just in general, watching portion sizes, but we also need to be sensitive to your preferences. What are your cultural foods? What are your favorite things? What is your family tradition that you eat together on Sunday at your grandmom's house? And we need to know all of those things, and not just preach to you perhaps a quote unquote recommended eating plan. We should encourage you to continue to be enjoy eating, and not use judgmental messages when we speak to you. Not say good or bad foods. There are no good or bad foods. There are perhaps better eating patterns, but I like to tell my patients there are no foods that are completely off limits or completely off of your list of things that are okay. Healthy eating patterns are an overall view, and that's what we should be focused on rather than, exactly how much protein or how many grams of carbs. We should individualize everything we do for you. Every person with diabetes needs to be the center of that conversation. They need to tell us what they want and what they would enjoy, and then let us see what we can do to help them achieve that, and help them with achieving better blood glucose levels. It does help to see a dietitian who knows about diabetes. So it can help lower blood glucose and A1Cs in the average of about 2%. So most of the research we have on eating plans can be boiled down to focusing on more non-starchy vegetables. And again, like I said, whole foods, minimizing extra added sugar and those refined grains, and as much as we can getting a good variety, a colorful plate, and that's again considering your religious practices, your health beliefs, your physical activity. All of that should be part of the picture. There is some interesting new information. This is chrononutrition joined the standards of care, I think, last year. But there's some evidence that what your eating time schedule looks like can really influence the way that those particular foods affect your blood sugar. You can eat the same thing, but at different times or in different patterns, and it can do different, have a different effect on your blood glucose. So you may have heard this, but that circadian rhythm really does matter when it comes to blood sugars and glucose. And there is a lot of evidence that shows that if we can eat breakfast like a king, or larger meals earlier in the day, a little lighter at lunch, and then a little less at supper, perhaps with a little more protein or fat in that evening meal, that we can see better blood glucose levels. My children are all night owls. I happen to be a morning person. So it's always been my habit to eat a good breakfast. And they might not ever eat breakfast, or they might eat a bigger lunch or dinner. And we're learning that if you can gradually kind of change that pattern a bit, it may help with blood sugar control. The other thing that's very interesting is the order in which we eat our food. So we eat our vegetables first, then our protein source next, and save carbs for last. We are able to see that the blood glucose 2 hours after that meal is lower. So it's an interesting new area of exploration. There's a lot of research going on. The big picture is that there are a lot of different behaviors that can help with you being your best and your health being the best it can be. And a lot of that is based on is in the guidelines, and it's based on breaking up your sitting every 30 minutes. We were just talking about having a standing desk if possible, or taking a break every 30 minutes and taking a my Fitbit fusses at me and says it's time for you to go get your 250 steps this hour if you've been sitting too long. Adding some resistance exercise can make a difference. If you just increase your daily step count by 500 steps, it can significantly reduce your risk for heart disease. We know that you can split up your exercise into shorter segments, and 10 minutes at a time is fine, but doing that and using the opportunity to break up the sitting is very important. They're actually calling sitting the new smoking. So resistance exercise and balance and flexibility also matter, especially as we get older, to prevent falls and to maintain independence and mobility. And again, big emphasis on sleep. Now, this is another really important topic. I think we have not been comfortable as healthcare providers, perhaps asking these questions, but we should. Diabetes is a difficult job, and it is full-time and 365 days out of the year. You never get a break, and that does wear you down over time, and especially when other things, like I said, happen in your life that complicate your care for yourself, because you have other people you're caring for, other challenges. So we should be asking you about this when you come in. And diabetes related to stress is different from depression or anxiety, but it's important to realize that it's a very strong influence on your A1C. It's more related to the challenges of living with diabetes day to day, but it can significantly increase glucose levels if you're not aware of it or you're not asking for help. Fear of hypoglycemia is another big challenge. When we talk about diabetes related distress, anything that causes you some stress or distress that has to do with taking care of your diabetes, we should be screening for this when we see you. There's a short form of an assessment. It's only 2 questions. And then there's a 17 question assessment, and those are available on the internet. If you're having a particularly tough season of life, it's not a bad idea to perhaps even go online and take this test yourself and report that to your caregiver, all your care team, so that they can make a referral if they need to someone that can then help you. There's no reason to suffer with that and not get some help if you need it. This section 6 talks about how important it is for us as your healthcare team to talk to you about what your goals are for your glucose levels. I know I take care of nursing home residents that have diabetes, and as you get older, the hypoglycemia becomes just a much greater risk. Those of you who take insulin are always aware of the risk of low blood sugars. And 25% of people living with diabetes say that hypoglycemia is a serious concern for them. They worry about it. It causes them stress. We know that also you may not want to wear a pump or have a CGM that fusses at you all day about which direction your glucose is moving. We know that you may not want a really complicated medical plan, and you need to tell us those things when you come to the clinic. We need to be asking that. But we also know that in the standards this year, they mentioned hypoglycemia 853 times. That's really come to the forefront, and your healthcare provider should be asking you about hypoglycemia and should be asking you about the challenges there. When we talk about goals for your glucose control, you can see that it's important that we consider the stage of life that you're in, the stage of your health at this current time and what your desires are, what you want. The better health you're in and the perhaps fewer years you've had the diagnosis of diabetes, we might ask you about setting that A1C goal closer to 6.5% or 7%. If you're active and healthy, even at 60, 70, and you're able to take care of all your medications and keep track of those things without challenges, without cognitive issues or memory issues, then 7.5 is a A1C goal that might be perfect fit for you. But as adults age and as they have fewer people to support them in their care, or as their health conditions um, become more serious as they age, we should be more aware of allowing those A1C levels to be higher. And then we know that A1C is not the be all end all. We know there's some challenges with A1C being accurate or being a really good picture of what's going on. It's an average. So if you have some hypoglycemias, but you also have some higher glucose levels, when you average those out, they look mighty good. They might be an A1C of 7, but that doesn't mean that you're not experiencing some low glucose levels that need our attention, or some high glucose levels that make you feel bad as well. So the continuous glucose monitor has been a really big asset, and it's a game changer for most people. If you don't already have one, just be aware that you can buy one over the counter and wear that sensor for a couple of weeks, and you can get the data from that sensor. It can tell you that perhaps every night at 2 a.m. your blood sugar is dropping low, but you didn't know it. It can help a healthcare provider adjust your medications and help do some problem solving if you see that there are glucose that go above or below the range that you would like to keep them, and what might need to be changed about your medications or about when you exercise or even your meals and what your carbohydrate intake is. But time and range in that sensor is very helpful when we get to looking at how we can help you feel better and maintain more realistic glucose goals. This is what that report might look like for those of you who don't have a CGM or you've not seen that. But you see at the bottom there where the green is the goal for your glucose levels. Below 70 would be those below the ideal range or low blood sugars, and the red or the orange above is higher than perhaps what we would prefer. But what's important to realize is I could be sticking my finger 2 or 3 times a day. Perhaps my blood glucose look beautiful. Well, that might be because I am checking them when that glucose just happens to be in my goal range. I might be completely unaware of those blood sugars that are low at 3 in the morning. So this is a really great tool. One thing that I really think I've been in healthcare like Donna for over 40 years, and I've seen the times when the doctor was the expert and he pointed his finger at you and expected you to do it. And if you didn't, he might call you something really inappropriate like non-compliant. You didn't do what he told you to do. But again, just like Josephine, um, you might have challenges that we're unaware of if we're not and if we're not putting you at the center of our care. So we need to make sure that all of you are in the middle of this healthcare team. You are the most important member of the healthcare team, that we are asking you about your goals and about your support and about your challenges. It hopefully will help us come up with a better a care plan that you direct, and help you stay healthy and help your quality of life to be maintained, and help with continuity of care when you have to change physicians, or say if you you probably, if you know folks with type 1, they have to transition from seeing a pediatrician to seeing an adult care team. Those transitions are hard, and we need to be more aware of the things that help give you emotional support and safety during those changes. We want to help to keep you healthy, and the way to do that is to give you good person-centered care. All right. We still have a few minutes for questions.
Yes, we do. Thank you, Kathy. That was a lot of information covered. There's a lot to take in. That was such a great presentation. And we do have some questions, so we're going to see how many of them we can get to. If you want to take down your slides, we can
All
start to
righty.
tackle the Q&A. Thank you. So Mary Lynn asks, she mentions that board certified health and wellness coaches could be such an integral part of the medical team for those of us living with diabetes. The purpose of coaches is to help clients set and reach prevention and healthcare goals. Do you anticipate increasing the use of coaches to support and help implement doctor, RD, certified diabetes education specialist recommendations?
Absolutely. And I'm just praying that we have, we have a shortage of physicians in Mississippi. We have a shortage of all of the above, dietitians and diabetes educators. And what I am so impressed with, and this is just human nature. But, if you have someone who has type 2 diabetes and they've been trained as a coach, or they have type 1, or they have family members that live with the disease, and they're able to relate to you in a different manner, a completely different manner, just like you guys with Diabetes Sisters being able to empathize and understand. I think health coaches can be amazingly helpful, and I think I've watched those people who have never really felt comfortable interacting with a physician or interacting with, say, a dietitian as such, feel comfortable talking about the challenges and sharing and being able to really take take away one great new step they can make. And in our area, again, we're rural, little health departments with a certified health coach could make a tremendous difference for those people who are not going to be able to get to the big city and come to a diabetes class.
Certainly. Yeah, agreed, agreed. I know it can be scary to be in that doctor's office with the physician, so sometimes working with a coach does make us more comfortable.
Mm-hmm.
Okay. An anonymous person asked, with the increasing emphasis on diabetes technology, how do I know if a CGM or an insulin pump is right for me?
Oh,
What's your
that's an excellent
thoughts on
question.
that? Yeah,
Excellent question. Um, I think that's part of what we should explore with you when you come to clinic, especially. But I think it's also great to know someone like within the Diabetes Sisters community, or a health coach kind of person that can give you the pros and the cons, and um, the benefits versus the burden of treatment, if you will. Sometimes the cost is, of course, an issue, and I think that's challenging. It's if you're not sure, um, especially like with a CGM, if you're not sure whether you really want to wear a monitor all the time, as I said, you can ask your care team if they have a CGM you can borrow, because a lot of the physicians have a professional CGM that they will let you wear for a couple of weeks and then return to the clinic with it. Um, it will give you a great test run, if you will, and you can see if it's helpful for you. And if it really drives you crazy because it's beeping at you when your blood sugar starts to drop and you don't like that, you'll find out over a couple of weeks. I've been to a training or two or three of those where we wore the CGM. I don't have a diagnosis of diabetes, but I wore the CGM for that 2 weeks. And I learned a lot about the way the different foods I ate affected my blood sugar, and about how exercise affected my blood sugar, and about how stress affected my blood sugar, and all of those things. So I'm curious, and I like it to think of it as a science experiment. But if you're interested, certainly asking someone who has experience wearing a pump or wearing a CGM, or talking with um, a healthcare provider who can really give you the pros and cons and the benefits. It's worth a looking into, because we found that it has decreased the number of hospitalizations um, by about 50%, for those living with diabetes, because they can see that glucose starting to rise and perhaps get really high when they get say an illness or the flu,
Mhm.
and they know before they get to that level that they have to go to the emergency room, um, that they should seek some care, some extra help. So it's a nice tool, but it's not for everybody.
True. Yeah, that is true. Thank you. Someone else is asking, as a type 1, as a person with type 1, what makes the provider give a type 2 diagnosis as well? So I think I've heard talk of like double diabetes. Does that happen? Do people get double diagnosed?
That is an excellent question, and that's actually in the standards this year. I didn't
Yes.
go into that because it's a little complicated, but there have been a lot of talk and a lot of guidance for providers about people get misdiagnosed quite often,
Mhm.
um, because we know now that about 50 to 60% of those living with type 1 also may have some insulin resistance, um, some challenges dealing with the glucose levels, just like those living with type 2. So they call it type double diabetes or type 1.5 a lot of times. But I've had a client that was, the healthcare provider just kept insisting that they had type 2. That particular client worked their butt off trying to
Mhm.
eat perfectly and exercise and do all the things that were recommended, and glucose levels still rose very high after meals, and it was just so obvious to me that that person needed some insulin. But the healthcare provider kept saying, but they're not like, I don't even want to say the word, but like a typical type 1 who's thin, and they 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 just don't fit the profile for type 1, but they also don't really fit the profile for type 2. So it's
Right.
important to recognize that in the standards this year, there's a lot more guidance for care providers about teasing out and getting an appropriate, accurate diagnosis, because that can really, this poor gentleman went a year starving himself trying to keep his
Ugh.
glucoses in control, um, and they were still elevated as A1C was still elevated. And it was because he actually was a type 1
Mhm.
and the
Wow.
diagnosis was not correct.
We hear that a lot too. Yeah. Yeah. It's hard. It's hard. We're almost out of time, but I'd like to squeeze in. We have a couple really good questions still that I'd like to squeeze in. Um, this one came in fairly early. Is there anything in the standards about menopause and diabetes? And then one of your slides, you mentioned that it's a new topic. Is there a little more you can tell us on that?
That's a really good question. And as I said, I went through just a year or so there. It was premenopausal, where I was so frustrated, and my OBGYN just wanted to put me on an antibiotic every day as a prophylactic treatment, but I didn't want to take antibiotic every day. I thought there's got to be a reason. There's got to be another uh, approach we can take. And as it turns out, we're learning much more, and the standards do address it this time. We should be making a better effort to talk to our patients, our female patients, about sexual health and about all the changes that occur with menopause and all the options that you might have in terms of hormone replacement therapy. There's a whole lot more evidence out there. I know for a while, you couldn't talk to a woman who said, she said, I might give up a lot of other things, but I'm not giving up my estrogen. And of course, then there were the studies that showed that perhaps there was a tie between estrogen and breast cancer. And then nobody wanted to take estrogen because they were afraid of breast cancer. And
Mhm.
then we've kind of finally in our knowledge base grown to know that it's there are a handful of folks that probably should not take estrogen, but there's a lot of other people that hormone replacement therapy may be safe and appropriate.
Right. Thank you. And one more, and before we close it out, someone is asking, how do those on Medicare afford newer drugs like Farxiga after they leave commercial insurance? Do you have any thoughts on that? I know that's a complex question.
No, I just turned 65. This is my first month on Medicare. So yes, I completely understand some of that frustration and some of that those challenges. One thing that I would encourage you to think about is, and sometimes it's on the healthcare provider, it's going to have to do a pre-authorization, which is just kind of a delay tactic by Medicare, I think. But in many cases, that your healthcare provider will need to say, this is why I'm prescribing Farxiga. I want to protect this person's kidneys. I want to prevent perhaps damage to their kidneys. They have diabetes. They have, early kidney disease. And if they will justify the reason that you need those medications, it does take probably 2 or 3 times interacting with Medicare to get an approval. Don't give up. But what we're excited about is several of those drugs have been around now for a little longer, and there are some generics available of the GLP-1. Just this year, there's new generic on the market, and some of those I call them the Flozins, but the drugs that protect your kidneys also, 1 or 2 of those will be generic coming really soon. So you just have to fight for those prescriptions to be paid for. And
Okay.
it's a
That's
challenge.
good to know.
It is a
Sorry.
challenge.
Yeah, it is a challenge, but it's good to know that there is something you can do and you can fight for it. Well, thank you. We've covered some of the biggest updates, from early screening and new treatment options to advancements in diabetes technology and personalized nutrition. We think the key takeaway is to stay informed, and Diabetes Sisters is happy to help you with that. Diabetes care is evolving to be more personalized, proactive, and technology driven,
Yes.
and it equips us. We're more equipped with better tools to manage our health. And another key thing to remember is that small changes can lead to big improvements in our well-being. Before we close out, I want to remind you that Diabetes Sisters keeps you informed this month with an exciting lineup of upcoming webinars and workshops. We'll be kicking off a weight management series on March 13th with a webinar on obesity, health equity, and advocacy, stories of change, strategies for action. And then you can join us on March 19th and 26th for a hands-on support group workshop, 2 hands-on support group workshops, Everybody Covered, Raising Your Voice for Obesity Healthcare Coverage, which we'll talk about some advocacy there. We're also planning to continue our T1D screening series with Taking Action, hands-on workshops for type 1 diabetes screening, an important topic. Those will take place on March 20th and 27th. And then on March 25th, we continue our diabetes prevention series with a hands-on support group workshop with tips and strategies for those at risk, a unique opportunity to learn from the experience of others. This is a participant-driven workshop. meaning that you lead the conversation. Join us, bring your questions, share your experience, and connect with others who are also on your journey. I want to give a huge thank you to Kathy. You're such an incredible speaker. Thank you for sharing your insights and expertise with us today. And to everyone who joined us, thank you for your time, your engagement, and your dedication to staying informed about the latest in diabetes care. Have a wonderful day, and we hope to see you at our upcoming events.
Thank you, guys.